Okay, good morning, everyone. Thank you so much for joining us today. I'm Selvi Thirumurthi. I'm a gastroenterologist at MD Anderson Cancer Center. I want to thank Raju for giving me the opportunity to use one of his Sunday endoscopy refresher Zoom rounds to discuss this topic. As Raju said, this is going to be a little bit different. There's no video of an EMR. This is, but I think, an important topic nonetheless. We'll try to keep Dr. Graham entertained. I'm honored to have as my co-host today, Dr. Silvia Sanduleanu from the Netherlands. And she's an expert in hereditary and high-risk colon cancers. In addition to thanking Dr. Raju, who will be one of my panelists, I welcome Dr. Roy Sutikno from California and Dr. Joseph Zhang, who is one of our colleagues at MD Anderson, to keep the discussion going. So as I said, this is something a little bit different. We'll have a case, and the case is a patient that I saw at MD Anderson earlier this year. And Dr. Silvia will be helping me explore some of the teaching via mastery learning. So that's a new concept, a different concept from how we traditionally teach medical education. And so that will be demonstrated today. So let's get started. Some of the learning objectives for today's session is to be able to recognize hereditary colon cancer, to identify some of the genetic tests that help us diagnose specific types of hereditary colon cancer, to recognize when to refer patients for genetic counseling, which is sometimes a question that we have, and also when to refer patients to surgery. And whenever you refer a patient to surgery, the patient always asks what kind of surgery they're going to have. And so we need to be able to answer that question also. We'll identify some of the concomitant conditions that can happen in patients with certain types of hereditary colon cancer. And lastly, whether the patient undergoes surgery or not. Once you've diagnosed a patient with hereditary colon cancer, they're your patient for surveillance or high-risk screening procedures. And so we'll go over some of those strategies as well. So we'll get started with my case. This is a 63-year-old man with no personal cancer history. He presents for a routine screening colonoscopy. So I see him in, it's open access. So he presented to me on my endoscopy day. I saw him in the pre-op area. And as part of the pre-op evaluation, I reviewed what his last procedure was and what the findings were. So in 2017, 3 years prior, he had 4 tubular adenomas removed from his colon. 2 of them had focal high-grade dysplasia, and the recommendation was to repeat the exam in 3 years. And this is why he presents to me in endoscopy. So these are pictures from his exam in 2017. So we'll go with poll question number 1. Raju, if you could launch the poll for us. When eliciting a family history, it is important to ask about which family members. Do you want to know about the patient's children? Do you want to know about the patient's parents and grandparents? Are you interested in the patient's spouse's family history, or the patient's parents, grandparents, aunts, and uncles? Please put your responses in, as some have already done. Okay, Raju. So the correct answer is patient's parents, grandparents, aunts, and uncles, and 63% of people chose this answer. So we'll go on and give a little bit of feedback now. Silvia, do you want to take over here?
Answer D is the correct one indeed. And I'm glad to see that many of the participants did well. Actually, the critical elements of a family history are first the lineage, which family member had cancer. Is he or she a first-degree relative, like parents, brothers, sisters, children, or a second-degree relative, like grandparents, aunts, uncles, cousins? And because our patients usually recall no more than 2 generations, we don't go further about third-degree relatives because information is in most of the cases not reliable. The second question we want to know is what type of cancer did they have? Did they have colorectal cancer, or did they have other so-called Lynch tumors like gynecologic tumors, especially endometrium carcinoma or ovarium carcinoma, gastric, pancreas, bile duct cancer, urinary tract, brain cancer? So these are the first questions. And we always ask what was their age at cancer diagnosis, which is also very important. A young age at cancer diagnosis, and I will call young age under 50 years, is raised the suspicion of a hereditary form of colorectal cancer.
So when I asked our patient about his family history, as I do, or at least try to do in pre-op when I see patients for screening colonoscopy, he said that his mother, his maternal grandmother, and maternal uncle all had colon cancer diagnosed in their 60s. So we'll go to poll question number 2. Go ahead and launch the poll, Raju, please. After talking to his family, the patient recalls many family members had cancer. Which family events will increase his risk of having colorectal cancer? Is it if his mother had breast cancer at age 65? Or if a maternal uncle had prostate cancer at age 60? If his son had leukemia at age 25? Or if his maternal grandmother had endometrial cancer at age 45? Please put in your responses. Okay. So there's the results, and the right answer is maternal grandmother with endometrial cancer at age 45. So I thought it would be nice to discuss some additional points. So what are some methods that we can use to incorporate family history assessment in the pre-op area? I think it's important for us to ask about family history, especially with an increasing awareness now of colon cancer, especially increasing rates of young onset colon cancer. These patients are coming to us with questions, presenting for colonoscopy. So I'll say what I generally do, and maybe some of our panelists can weigh in also. I always do ask about family history whenever I have patients who come in for a screening colonoscopy, or if they're coming in for an upper endoscopy procedure as well. And I ask about gastric cancer history. And I think this is where it would be nice for some of our endoscopy nurses in pre-op to get involved in getting a family history assessment. I think incorporating some of this in a protocol-driven fashion will increase our yield of family history. So Raju, and Roy, what do you guys think? What do you do, and what do you suggest?
I think, first of all, this is a very important point that we need to discuss. What I envision a good endoscopy nurse should do. A good endoscopy nurse, by the time they bring the patient into the room, they should remember what that patient has. Why are they coming? What medical problems they have that would put them at higher risk for the procedure, and whether they are on any antithrombotics. In addition to that, a good endoscopy nurse should also inquire about the family history, like you talked about. That's what makes endoscopy nurse a complete nurse. A nurse should not be looking at the records to figure out why she brought a patient into the room. So I want to make this point for any nurse that is on the on the Zoom today, to get into the habit and make it a habit to learn about the patient before you wheel that patient into the room, rather than just bringing the patient and then checking everything in the EPIC.
Thank you, Raju. I think that's awesome if we can make this into a system like that. This is one point that I'm quite concerned about, that family history seems to be not valued as much as many patients come in for their screening or surveillance. This is one point that I always double check after the history from the fellow is given to me just before the patient is sedated. I always talk to them and ensure that the family history is correct, because without it, it is very hard to make the observations that we have to do in the room, and also how to plan for the post-operative surveillance. This is key because some cancers are accelerated, and when we give the wrong surveillance, then we could cause harm.
Okay, thank you for your comments. We will keep moving on. So during this procedure that I did for this patient, these are some of the findings. So he had 5 polyps in addition to the ones that you're seeing, what you're seeing from the left colon. He had 5 polyps in the proximal colon, and one was a tubulovillous adenoma, one was a sessile serrated polyp, and 3 tubular adenomas. And we'll come back to these endoscopic findings in the left colon a little bit later in the presentation. So let's go to poll question number 3. This patient most likely has familial colorectal cancer, hereditary colorectal cancer, sporadic colorectal cancer, or polyposis-associated colorectal cancer. Please put your choice in. Okay. Okay, looks like 50% of people said hereditary colorectal cancer. And that is the correct answer. So we'll move on to, we can stop sharing the results. And Silvia, go ahead.
Yes,
please.
Thank you. So, yes, indeed, this is hereditary form of colorectal cancer. Let me explain why. As we know, about 70–80% of all colorectal cancers are sporadic. About 20 to 30% are familial colorectal cancers, and less than 5% are hereditary colorectal cancers. And Lynch syndrome is the most common form of hereditary colorectal cancer. And I would like to firstly clarify the terminology. So may I have the next slide, please? Sporadic colorectal cancer is caused by harmful environmental factors, as we know, such as diet factors. Familial colorectal cancer is caused by a mix of environmental and genetic factors, but we should keep in mind that the underlying genetic alterations are largely unknown. And in contrast, hereditary colorectal cancer is caused by a demonstrated gene mutation with either autosomal recessive or dominant inheritance pattern. Lynch syndrome is caused by a germline mutation in a DNA mismatch repair gene. And regarding terminology, I would like to make one more point. Lynch syndrome and HNPCC, or hereditary non-polyposis colorectal cancer, refer to the same condition, but the later, the term hereditary non-polyposis colorectal cancer is actually obsolete and should be avoided. In the past, hereditary colorectal cancer was subdivided into polyposis syndromes, such as familial adenomatous polyposis, attenuated FAP or MAP, and non-polyposis syndromes, such as Lynch and familial colorectal cancer, just to make a distinction between cancers with multiple polyps and those with only few polyps. In Lynch syndrome, we usually see no more than 10 adenomas, while in polyposis syndromes, we see myriads of polyps in familial adenomatous polyps or up to 100 in attenuated FAP. So the historical term HNPCC suggests that cancer does not arise from polyps, which is not correct. That was the point I wanted to make. So cancer in Lynch arises also from polyps. And that is why this term was abandoned and replaced by Lynch syndrome after the name of Henrik Lynch, who firstly described it. And can we go to the next slide? We all know the Amsterdam criteria, the 3-2-1 rule, and the Bethesda criteria. I will not go into detail. Unfortunately, they can detect only half of the patients with Lynch syndrome, having a low specificity. So the question is, should we still use this criteria? And my answer would be yes, we should still use them for at least 2 reasons. They are simple tools. It takes us only 1 minute to know whether the patient fulfills the Amsterdam criteria or revised Bethesda criteria and whether they need further genetic evaluation or not. And second, as clinicians, we know there are very few pathognomonic signs and symptoms in medicine, yet we take a detailed clinical anamnesis in all patients because this guides our clinical decision. So by doing so, we create mental representations. So that is why I will still encourage using this clinical criteria. In the meantime, we have computational risk prediction models like PREM model and like the validated 3-question tool, which was recently published. And I think that all together, these tools can give us orientation and help to further evaluate the patient and refer to genetic department when needed. So we know the criteria. I will not go into detail. I just summarized them in this slide. Again, the specificity is only 50%.
Okay, thank you, Sylvia. We'll go on to poll question number 4. So after performing colonoscopy, which of the following would you order to confirm the suspicion of Lynch syndrome in the patient that we're presenting? Would you order a CEA, immunohistochemistry for mismatch repair gene expression? Would you order an APC gene mutation, a BRAF mutation, or a CBC, liver panel, renal tests, and an INR? Looks like people would order an immunohistochemistry for mismatch repair gene expression, and that is the correct answer. Okay, we'll talk about tumor testing, what and why.
Yes, so going back to the question, carcinoembryonic antigen is not a correct answer because, as we know, this is a marker of tumor progression, so it will not help us to confirm our clinical suspicion of Lynch syndrome. APC gene mutation would help us to detect familial adenomatous polyposis or attenuated FAP, so not a Lynch syndrome. BRAF mutation might be useful in a later stage to rule out a sporadic colorectal cancer. I will go into detail. And of course, the last tests would be useful to evaluate the patient preoperatively, but will not help us to confirm the suspicion. So which tumors can be tested? This is my first question. We test colorectal cancers, but also perform genetic testing on other Lynch tumors like endometrial, gastric, renal tumors. First step in the diagnosis is universal tumor testing for mismatch repair deficiency or microsatellite instability, which is defined as changes in the length of nucleotide repeat sequencing of tumor DNA. And because defective mismatch repair genes lead to microsatellite instability, these two tests, immune histochemical testing for MMR and microsatellite instability, are highly correlated. And we should keep in mind at the same time that the sensitivity of microsatellite instability is somewhat low, is about 80–90% for MLH1 and MSH2 mutation, but it's lower for MSH6 and PMS2 mutations, while the sensitivity of immunohistochemical testing, regardless of the gene involved, is about 85% for the same specificity of around 90%. The second step in diagnosis is exclusion of a sporadic cancer. And we should keep in mind that deficient MLH1 gene can be found in Lynch syndrome, but also in some cases of sporadic cancer. And two tests can help us to distinguish between Lynch syndrome and sporadic cancer. First is a BRAF gene mutation, which is present in sporadic colorectal cancer, but not in Lynch syndrome. And second, hypermethylation of MLH1 gene promoter, leading to somatic silencing of the MLH1 gene, which is a sign of sporadic cancer and not Lynch syndrome. And may I have the next slide?
I just wanted to say one thing, Sylvia, here, just
Yes.
for clinical correlation for the gastroenterologists and even the endoscopy nurses and that are on the conference. So this information can be found on your pathology report. So whenever you have a patient who's had a colon cancer, I generally review the pathology report and will look to see if the patient had colon tumor testing. So it's supposed to be universal, but I would suspect that it is not, in fact, universal, and that not all tumors are actually tested for either immunohistochemistry or for microsatellite instability. So I think it's important whenever you have a patient that you're doing surveillance on who had colon cancer in the past to look at their original pathology report. At MD Anderson, we either run the tests ourselves or it's run on tissue that is obtained. Sometimes patients come in diagnosed outside of our center for further treatment and follow-up at MD Anderson. And those outside specimens are indeed tested for IHC or microsatellite instability. So I would encourage people to start looking at the pathology reports in detail and trying. That's how you kind of start learning, getting familiar with the terminology and the findings. And I think it will be a good reinforcement of what we're all learning today when you start go back to work tomorrow morning.
Sophia,
Yes.
can you explain whether we can test this on adenomas before it's a diagnosis of cancers? And I think you will talk about when we should be doing this, right?
In our protocols, only colorectal cancers are testing for microsatellite instability. I know that the pathologist can diagnose sometimes the mismatch repair gene deficiency by immunohistochemical testing in advanced adenomas, but usually we think that the most reliable diagnosis is performed in tumor material and not adenomas.
Thank you.
And may I ask a question to Selvi, please?
Yes, of course.
Yeah, I very much agree. It is universal testing, but actually it's not an ideal. In real life, we see a lot of situations when it is not performed. Do you have an age limit in the United States for universal testing?
So that's an excellent question. Generally,
Yeah.
with patients who have colon cancer, I think under age 70, they're supposed to get tested.
Exactly.
But again,
same-
you know, in our center, there is not universal testing in our pathology department. We, a clinician, needs to order the test on the tumor ourselves, and then the pathologist will run it. And that's just a protocol related issue, and we've discussed it with our GI pathologists over the years, and that's just how things are done at our center. I think there's some concern from our GI pathologists about if they run the test, then who is the clinician that they would relay the results to, and they don't want results to fall through the cracks and not get picked up. So that, I think, is the rationale that our GI pathologists have presented. But yes, so I will usually order the testing myself. It's just a separate biomarker order set within our electronic medical record, and then it gets resulted and it comes into our little in basket with results.
The situation is pretty much the same here. So thank you.
Okay.
Thank you.
Okay. Anything on this slide, Sylvia, or shall I move on to the next one?
I think we can move to the next question.
Okay. So going back to our case patient, he reports that he has been seen by dermatology and he's had some skin lesions removed in the past. And I went through his medical record, and these are the lesions that were seen and photographed by our dermatologist at MD Anderson. We'll leave the pictures up while people are answering the poll questions so they can see the image. So is this a melanoma? Is this actinic keratosis? Is this a sebaceous adenoma, or is this basal cell carcinoma? What do people think? It might be related to why we're presenting this case, just a clue. Okay, that's good.
Selvi,
Yes.
we are supposed to recognize the skin lesion and see if there's a connection. Not necessarily thinking that, okay, we are presenting a Lynch syndrome, so pick up the skin lesion.
I'm just trying to help people get the right answer, Raju.
No, you need to make sure that they think right and then come back to this thing.
Okay, so 38% of people thought this was a sebaceous adenoma, and 38% of people thought this was a basal cell carcinoma. So the correct answer is sebaceous adenoma. So we'll move on to extraintestinal tumors that are related to Lynch syndrome. Sylvia, go ahead.
Yeah. Yes, thanks a lot, Selvi. I think Professor Raju made a very good point. This is a skin manifestation which can be found in less than 1% of the cases of Lynch syndrome. So it's a very uncommon extraintestinal tumor. I have summarized the most common extraintestinal tumors in Lynch syndrome by gene mutation in this table. So we can see that Lynch syndrome, patients with Lynch syndrome with MLH1 gene mutation often have gynecologic tumors, gastric, small bowel, pancreas, bile duct, urinary tract, brain, and also skin. While those with MSH2 gene mutation have endometrium, ovarium, and also urinary tract tumors, while MSH6 and PMS2 mutation carriers have more often gynecologic tumors. And I also included the lifetime risk of cancer at age 70, for colorectal cancer and endometrium cancer, subdivided per gene mutation, just to show you that PMS2 gene mutation is associated with much lower risk of colorectal cancer and than the rest of the mutations. So why is important? Yes.
So not all Lynch syndrome is created equal. There seems to be some differences between the different mismatch repair genes that are mutated in Lynch syndrome, Sylvia.
Exactly.
Yeah.
And I would like to make the point that there is a high inter-individual variation. Also within the same Lynch family, mutation carriers will show wide variability in their tumor spectrum. So we will see, let's say, a child with a ganglioblastoma and a grandmother with endometrium carcinoma at younger age. So very diverse spectrum. So the take-home message is that we should be alert and take a detailed family history. And when it's not possible to combine this detailed family history with the endoscopy procedure, I think pre-screening, at the pre-screening of these patients, we can get more information and reliable information. For example, we used to send them a questionnaire before the colonoscopy and also ask details about their family history, or before the procedure, if a nurse is available, we ask them indeed to take more details about the family history. And once the clinical suspicion is formulated, they will be extensively evaluated at the genetic department, and the tumors will be checked for histological diagnosis, because a lot of patients will tell us, well, I have an aunt with gynecologic tumor, but that tumor could be a cervix carcinoma, which is not a Lynch tumor. So this kind of details are difficult to obtain, to be obtained during the colonoscopy, before or after the colonoscopy. We should see the patient maybe at a different moment. I hope it makes sense.
Definitely. Okay,
So
we'll move on. Oh, go ahead.
let's go back. So for the sake of fellows, if you want to figure out a way to remember, because you need to figure out which cancers do you need to screen if you have one type of Lynch syndrome, right? We all screen other organs. So MLH1, MLH1L, there's a long list of tumors, right?
Mhm.
Whether it is a colon, endometrium, ovary, gastric, there's a long list. So you have to keep that thing as a long list of cancers. And MSH2, there are only two, genital and urinary. And then if you look at the other ones, if you keep those things in mind, the other ones are just colon and genital, that is endometrium and ovary. That's one way to keep in mind if you want to remember. Other than that, you have to keep a card in your wallet to see which cancers you need to screen. So I'm just thinking through this thing, how am I going to remember this? Because if I have an MSH2, I need to send that patient's urine for cancer cell screening. Right, Sylvia?
Yes, I fully agree.
Right. So I'm just trying to help the fellows remember these different things, because there's a long list of tumors to remember. All right, thank you.
Thanks, Raju. That was a nice mnemonic. We'll move on to the next poll question, number 6. So the biopsy results come back for this patient that we found the colon tumor. And it says that the tumor cells have loss of MLH1 and PMS2 expression with intact expression of MSH2 and MSH6 by immunohistochemistry, indicating a high likelihood of microsatellite unstable carcinoma. So based on the pathology report below, what is the next step in the management of this patient? Should we refer the patient to a colorectal surgeon or to a genetic counselor? Or should you just go ahead and order the genetic testing yourself? Or should you check for a BRAF mutation or an MLH1 promoter hypermethylation? What do people want to do? Okay. So 48% of people want to refer the patient to a genetic counselor. 8% want to send him to a surgeon. 16% are willing to order the genetic testing themselves. And 28% want to order whatever this is, BRAF mutation, MLH1 promoter hypermethylation. Okay, so the correct answer is refer the patient to a genetic counselor.
Let me make a comment here to help people write questions a little bit better. Here, if you say colorectal surgeon, that's not wrong as one of the answers for management. But if you, I guess you are thinking what we should do to further define this problem further, right? From the genetic driver point of view, then that stem of colorectal surgeon should not be there because that's confusing. So you could take away that stem and put something else, right, like doing a CA level or something else, something unrelated to that management, because that causes confusion. When you think about writing questions, that's one thing to keep in mind.
So good point, Raju. None of these answers are necessarily wrong. So the patient does need to get referred to a colorectal surgeon. He has a sigmoid colon mass. Referring to a genetic counselor is certainly correct also, because you're recognizing that the patient has some findings of Lynch syndrome with microsatellite unstable tumor. So that's a possibility also. Ordering genetic testing yourself happens as well. So I see patients in my high-risk clinic where most commonly female patients have had genetic testing ordered by their gynecologist when based on a family history of breast cancer or ovarian cancer, and then they come to me with their genetic testing results. They have not seen a genetic counselor, and they kind of want to make sense of different mutations or what the different tests are. And checking for a BRAF mutation or MLH1 promoter hypermethylation is actually also correct, because those are the tests that need to be ordered or in the cascade testing based on these preliminary findings of MLH1 and PMS2 loss in the colon cancer.
That's good. I'm glad to hear that explanation. That's good. Thank you.
So here is, so the patient did go to, so we'll say that the cascade testing is happening in the GI pathology department. This is not something that we need to order, and technically it should be done by the pathologist whenever there is a loss of MLH1 and PMS2. But the patient was also brought to my high-risk clinic. I think it was within 2 days of his colonoscopy findings coming back. We saw him in clinic with my genetic counselor. So this is the level of detail that a genetic counselor is able to get from the family. And so this was a video visit because we're not doing as many in-person visits these days. And he was there with his wife on the video visit, and the wives are generally very knowledgeable about family history of their spouse, and they're able to contribute to kind of acquiring a more detailed family history. So this is this patient's actual family history that was obtained by my genetic counselor. So you can see that there's multiple cancers, and just running your eye down the column on the left, you see colon cancers, multiple colon cancers, and then you see some other cancers which are probably not related to Lynch syndrome or not as highly associated. So leukemia is not, breast cancer probably not, prostate cancer probably not. And then if you look at the middle column, you can see that most of the family history is accumulating on the maternal side. So when you're thinking about genetic disorders, you want to try to see if the conditions are falling on the maternal side or the paternal side, and then you can kind of see that the mutation may have been passed down from one particular side of the family. And then the third column finally shows that what age the cancers were diagnosed when that information is available, and you can see that there's a patient at age 26, and then 50s and 60s. So I included this table because I think it's a little bit easier for us to see, but this is the actual pedigree that my genetic counselor drew up, and it's very complicated. But you can see the proband here at the arrow is my patient, and all of the family history that comes from there. So we ordered germline testing, which is blood testing to look for Lynch syndrome mutations. And it was discovered that the patient had a mutation in the MLH1 gene. So the patient was also referred to a colorectal surgeon for colon cancer and for the descending colon polyps that actually had intramucosal adenocarcinoma. So I included some of these pathology pictures. I presented this case at our multidisciplinary GI pathology conference. So this first slide shows low power on the left and high power on the right of some of the descending colon adenomas that were removed. So in the lower left here, you can see that this is normal crypt structure. You can see the crypts are all evenly spaced and uniform looking, very, very pretty. And here on the right of this same slide, you can see that there's an area that is not so pretty. It's a focus where on the right, you can see under high power, there's a loss of polarity. The crypts are all kind of jumbled together. They're not ordered like you can see with the normal comparison on the far left. And there's adenocarcinoma, focus of adenocarcinoma on one of the polyps that is invading into the lamina propria and has not invaded into the submucosa yet. So here are some slides from the tumor that was seen in the sigmoid colon. So on the right is the low power and on the left is the high power. And you can see that there's definitely some disordered glands. There's complexity of the gland structure. There's a vigorous desmoplastic reaction so that the glands are not respecting each other's space. They're all jumbled up together. And this was moderately to poorly differentiated adenocarcinoma. So one of the things that we asked about at our pathology conference was if there were lymphocytes that were invading into the tumor. And there were indeed a few lymphocytes that were present in the tumor itself. So we'll go to poll question number 7. And we'll ask, what is the most appropriate surgical procedure for this patient with Lynch syndrome? Because I told him I was referring him to a surgeon, and his next question to me was, are they going to remove my entire colon? So we need to be able to counsel our patients on, give them at least some idea of what kind of surgeries will be recommended, of course, at the discretion of the surgeon, weighing multiple factors and the preference of the patient. So would you recommend a total proctocolectomy with end ileostomy, a low anterior resection, a left colectomy, or a subtotal colectomy with ileorectal anastomosis? What do people think? Okay.
Selvi,
Yes.
as you discuss the surgical results, explain what each surgery means.
Okay. So here we have our poll results, and we'll go to the next slide so people know so the correct answer is subtotal colectomy with ileorectal anastomosis. And Silvia will talk a little bit more about why this is the recommended procedure in Lynch syndrome. But total proctocolectomy is a total loss of the colon, including the rectum, the procto, with an end ileostomy. So since all of the colon is removed from the patient, the terminal ileum is brought up to the skin and a stoma is created, and that's a permanent end ileostomy. And so the patient would have that for the rest of their life. A low anterior resection is where this is generally the approach that is used by colorectal surgeons for sigmoid and rectal cancer. And they basically remove the tumor and then they can do either a primary anastomosis of the proximal end of the colon into the rectum or to the anus, so a colorectal or coloanal anastomosis, depending on the location of the primary tumor. So that's one option. They can either do it primarily or they can do it with a diverting loop ileostomy to allow the primary anastomosis to heal. And then generally 3 or 4 months later, they'll take the patient back to the operating room, take down the ileostomy because that's only a temporary ileostomy, and then reconnect the patient, and the patient's all connected again. The next option is a left colectomy. So that would be just a segmental removal of the part of the colon where the tumor is located. So for example, if it's a high sigmoid or a descending colon or a splenic flexure tumor, that may be the approach. And then the correct answer is a subtotal colectomy with ileorectal anastomosis, which means removal of the colon up to the point where you would get a clean distal margin from the tumor, and then anastomosis of the ileum to the rectum, and usually in a J pouch. And I have discussed this before on a previous Zoom rounds in the colon anatomy presentation, where it can be a J pouch anastomosis that is created. So if people are interested, please go back and look at that presentation on Zoom. Okay, Sylvia?
Yes, D is indeed my answer too. It's a challenging issue, and to answer this question, let's first talk about the risk of metachronous colorectal cancer in patients with Lynch syndrome who got cancer and underwent surgery. So the question is, what is the risk of getting a new cancer during the follow-up? Overall, the risk of metachronous colorectal cancer is approximately 60% at 10 years follow-up, 40% at 20 years follow-up, and 60% at 30 years follow-up. And more recent studies show even higher percentages. There are data that factors associated with risk of metachronous cancer should be evaluated, and patients who are older in age, males, with those with MLH1 mutation, and those with previous history of colorectal cancer or colorectal adenomas do have an increased risk of metachronous cancer. And back to our patient, he is an older male. He has an MLH1 gene mutation, has a prior history of colorectal polyps. So he has, in fact, multiple risk factors for metachronous cancer. And for these reasons, I think I would advise him to undergo subtotal colectomy with ileorectal anastomosis and endoscopic follow-up of the rectum. But the final decision should also take into consideration other factors like comorbidities, like patient's wish. And it seems that quality of life is a very important factor in their decision. And because this patient is an older patient, he's 63 years old, if I recall well.
Yes.
I think it takes only 14 years or something like that of follow-up. So if we would have a very young patient who will have 20 follow-up colonoscopies, we would rather recommend a total colectomy with ileal pouch and anastomosis. But in this case, we have to put in balance the two aspects. I mean, his risk of getting metachronous cancer is high, but given his shorter follow-up interval and his own preference, I think that this is still a good decision. Segmental colectomy, I mean.
So here's what the patient did. He was extensively counseled by the colorectal surgeon regarding his risk for metachronous colon cancers that Sylvia just explained. He was concerned about quality of life, and despite multiple conversations with him, he decided to undergo a partial left colectomy. Here is the pathology report from his partial colectomy. It showed invasive, moderately differentiated adenocarcinoma that was forming a 2.5 centimeter mass in the colon. The tumor was invading the MP, or muscularis propria layer. The margins of resection were negative for tumor, and there was no lymphovascular invasion, no perineural invasion. They sampled 26 regional lymph nodes. None of the lymph nodes were positive for disease. He was staged at a T2 N0 tumor, and 26 centimeters of his colon was resected. So this is a good prognosis. He has multiple good prognostic features here. The fact that there was no lymphovascular invasion is promising. no perineural invasion as well, and none of the lymph nodes were positive for disease. We'll move on to poll question number 8. So now he's had his surgery and he's going to require, obviously, since he still has colon left, colon and rectum left, he's going to require surveillance colonoscopy. How often should this patient undergo surveillance colonoscopy? Should it be 1 year post-surgery, 3 years post-surgery, then every 5 years for the rest of his life? Should it be every 3 to 5 years, as he had been getting before he got his diagnosis? Should it be in 10 years because his colon has been cleared of polyps? Or should it be every 1 to 2 years? Okay. So 67% of people thought every 1 to 2 years, and a third of people thought 1 year, 3 years, 5 years. So the correct answer is every 1 to 2 years. And we'll go on and talk a little bit about that, and Silvia will explain why every 1 to 2 years and why every in a year, 3 year, 5 years would not be the correct answer.
Okay. As we know, current evidence in this field is based on relatively small numbers of studies and a small number of patients per study, heterogeneous study populations, which included not only mutation carriers, historical cohorts included next to mutation carriers, patients with a family history of Lynch syndrome, which is a major confounder. And there are very few randomized controlled trials. So this is the level of evidence we have. I would just like to briefly go through this recent large international study involving almost 2,800 mutation carriers and examining the outcomes of 3 different surveillance regimens. Annual surveillance in Germany versus 1 to 2 yearly surveillance in the Netherlands and versus 2 to 3 yearly surveillance in Finland. They found no differences in colorectal cancer incidence or stage of cancer at detection among the 3 protocols. And interval cancers, defined as cancers detected before the next recommended surveillance exam, were uncommon, but still occurred even with 1 to 2 year surveillance intervals. Fortunately, Lynch tumors have relatively good prognosis compared to sporadic cancers, probably also because they are detected in an early stage, like in the case of this patient, and they respond well to chemotherapy. So based on these studies, surveillance guidelines recommend to start colonoscopy screening 10 years later in MSH6 and PMS2 mutation carriers than MLH1 and MSH2 mutation carriers. So I have summarized this data in this slide. In MLH1 and MSH2 mutation carriers, age of starting screening is 25 years, and we perform surveillance at 1 to 2 year intervals, while in MSH6 and PMS2 mutations, we start 10 years later, 35 years of age, and we perform the same with the same frequency, 2 yearly surveillance colonoscopies.
Thank you, Silvia. So when you're doing these colonoscopies, these patients may end up on your endoscopy schedule. So we should all know which of the following techniques is most appropriate for surveillance of patients with hereditary colon cancer. So is it use of high definition white light colonoscopy, high definition colonoscopy with equipment-based chromoendoscopy? So that could be narrow band imaging or any one of the other manufacturer's equivalent. Should we use high definition colonoscopy with dye-based chromoendoscopy? So that's using a spray jet and injecting a dye onto the surface of the colonic mucosa? Or should we do colon video capsule? What do people think?
Do you have any presentations this week?
Journal Club, but I don't have the article.
Really? Why are they so
I mean,
last
it's on the
minute with that?
20th.
Okay.
Well,
So
this remember next weekend you're working?
It's fine, baby. It's an article. Like 10 slides.
okay, so the correct answer is
You and I have different views.
high definition colonoscopy with dye-based chromoendoscopy.
Why chromo?
We're going to tell you why chromo. I'm glad you asked. So feedback on these points. Sylvia.
Yeah, indeed. I have heard a voice
Yes,
on the background.
I'm going to take care of it,
different
Sylvia. So go ahead,
Yes,
Sylvia.
of course.
I'm going to take care of it for
We-
you right now.
for dialogue. The 2019 ESGE guideline recommended the routine use of high definition colonoscopy systems in individuals with Lynch syndrome. It was a strong recommendation, high quality evidence, level of agreement was 100%, but also the ESGE guideline suggested the use of chromoendoscopy may be of benefit in individuals with Lynch syndrome undergoing colonoscopy. Routine use must be balanced against costs, training, and practical considerations. And what is the evidence we have? Actually, studies on chromoendoscopy for surveillance in Lynch syndrome show conflicting results. And I will not go through the literature, but I will just mention two recent trials, a Dutch and a Spanish trial showing negative results. But as a matter, in fact, they did not use a standard protocol for chromoendoscopy. The endoscopists did not receive formal training. And as far as I know, in the Dutch study, only the proximal colon of these patients was examined. So there are lots of limitations. We know that chromoendoscopy use of indigo carmine, so dye-based technique, is helpful to better delineate the borders of the lesions and to better classify the lesions. So it requires training. It requires a learning curve. So it's probably a subtle effect, difficult to measure, but still very important. And I would like to mention this old study from Japan in which 9 patients with Lynch syndrome underwent annual follow-up with a mean follow-up period of 12 years. And they found, despite using advanced technologies and indigo carmine, they found 7 advanced and 6 early cancers in these small populations. And remarkably, 50% of the early carcinomas and 50% of adenomas had flat appearance, the majority of them being located in the proximal colon. And if we go to the next slide, yes, this study at an academic hospital where endoscopists were trained in detection and resection of non-polypoid colorectal neoplasms showed that, and in which selective chromoendoscopy was applied for detection of non-polypoid colorectal neoplasms, patients with Lynch syndrome had almost 4 times more non-polypoid colorectal neoplasms than controls, especially in the proximal colon. So I think that chromoendoscopy helps us to better detect flat lesions in these patients and assist us in performing better quality endoscopic resections, in the end, reducing the incidence of interval cancers in these patients.
May I comment on this?
Certainly.
I think we have this illusion that there is this NBI, and then, oh, this is a patient with Lynch. Let's go do an NBI surveillance. Now, having done studies on chromo and done studies on NBI, I can tell you that the learning curve to do the chromo is actually much lower. Because here what we wanted to do is that we just wanted to like spray the blue dye in order to leave a very thin layer of blue on the mucosa so that we can highlight the border of the lesion. So the blue dye will have this preference to be at the edge of the lesion, and thereby just like highlighting, just like using a blue stabilo, so to speak. And here I am the lesion here, and all you have to see is that, oh, where is this area that has a round or circular border? And that's all you have to do. There's no um, kudo classification, there is no anything else. And then once you find it, then you look at it, and you can look at it at white light, you can look at it using chromo, and decide, oh, is this looking like a cancer? Is this looking like an adenoma, or is it hyperplastic? Uh, so that's all about the blue dye. Now there is a recent large studies from Spain that showed that expert and non-expert can find flat lesions equally well. This is in the setting of IBD, but it's just telling you that this is like almost no-brainer. We are all smart. We all have gone through our fellowships and things, or we are in the fellowship, and we can do this. Now, as compared to if you do an NBI, you really need to train your synapses or develop the synapses that you're going to be looking for something that's more browner. There are a lot of different things that are different colors with the NBI. And there have been many studies of detection of flat lesions using NBI. And really it works really on the hands of the experts. And it requires a lot of NBI examinations before you can get there. So I urge you, this chromoendoscopy has had a false uh, feeling from people that they think, oh, that's so difficult. This is really, really a simple thing as compared to everything else that we do. Thank you.
Oh, yes, thank you. So when you do this dye-based chromoendoscopy, Roy, can you tell us what kind of concentration of solution you use and how you actually have it hooked up to your scope? Is it on the foot pedal? Do you put an injection catheter out, or do you have the endoscopy technician put it through a syringe in the biopsy port? So what's the solution and what's the method?
So as part of the scenic recommendations, we have put out, and you can look it up in Google, chromoendoscopy for IBD, chromoendoscopy in scenic, and the method is very much the same. It's really you dilute 2 vials of indigo carmine in 250 cc of water, and then you mix it very quickly, and then you hook it up into your water jet, and you spray it onto the non-dependent part of the colonic mucosa, and then you suction excess blue. Here, the blue dye will be light blue, just like in this picture on the left, and you still can see through the pooled blue dye. But otherwise, if you can have this thin layer of blue dye, would be the most excellent. And you just look around. Is there anything that looks reddish on the mucosa? Is there anything that's makes this oval or circular highlighted structure? And you just like scan through it. It really just to help your brain to recognize these lesions. These lesions in IBD or in Lynch is like about 70% of all of their neoplastic lesions. That is very different than in non-IBD patients, which is about a quarter or so. So here, the best, even with the best endoscopists, just like what Sophia had shown in the prior slide, even the best endoscopists have a hard time to find them. So let's do our better efforts here to find these lesions, because they are notoriously at a higher risk to contain mucosal or submucosal carcinoma, and we need to find them before they become a deeper cancer.
Thank you, Roy. So we'll just in summary, what does the Lynch syndrome patient expect from us? The Lynch syndrome patient expects multidisciplinary team and having specialized centers that are dedicated to taking care of these patients. An optimal bowel prep. This is very important, especially if you're doing the dye-based chromoendoscopy, but even if you're not, a standard prep plus 3 days of diet plus bisacodyl. We expect that there needs to be proficiency in detection and resection of these non-polypoid lesions, and then availability of expert EMR and ESD capability. So when you see these large lesions and you don't feel comfortable removing them, or you have experts in your center, then those patients should be referred. And we should have experienced pathologists, preferably GI pathologists, who do deep sectioning of high-grade to detect high-grade dysplasia or invasive colorectal cancer. So that's all that we have. I'll leave these learning points up. Thank you very much for your attention. Thank you, Silvia, for helping me present this case and your expertise. And thanks to Raju and Roy for your comments that were shared as panelists. Raju, we can see if there's any questions in the chat.
Right. So good question from Emil, a good friend of mine from a long time back. He shares that he did a lot of chromo and white light in 1990s. Agrees it is easier to see than NBI, but once you do a lot of chromo, your eyes see these lesions much better with white light also, and your adenoma detection rate goes up. I agree with that, Roy, any thoughts on that?
I think that's an observation that we all have experience, and it is now I'm reading more and more on the psychology part of learning, and it is the one thing that Sophia talked about, which is mental representation. What that means, and what Emil was saying and Raju was saying, is that if you've seen maybe 50 of these lesions under chromo, and you say, okay, now you've seen the chromo, imagine what it is without the chromo, then your brain kind of just like can imagine and make this mental representation of what the lesions look like without chromo. So here is my concern that many of us, many of the trainees never seen chromo. So they by defect, by facts, they actually will have a harder time to find the flat lesions. I think we should have another conference where we actually show many of these lesions and try to train people the flat adenomas. It is very a sad story, part of the flat adenoma, that after we described it in 2008 of its importance in the Western countries, maybe about 3 years later, as many people try to understand how to find them, there was this conflicting story that has now been debunked, that is the SSA is as important. The importance of SSA is actually only 1/7 of the importance of the flat lesions. And that has caused a little bit of setback as to our ability as a community of gastroenterologists to find the flat lesions. I think it is time now that we correct it, that those proponents of the SSA have now understood that maybe we need to have sessions like this, whereby we really bring people into the understanding of how we should be finding the flat lesions. It is what we have shown in our prior study is that nobody is born with the knowledge to find flat lesions. All of this knowledge must be acquired.
I thought Roy was born with that.
No, it took us actually 1,000 colonoscopy to get to a stable level of finding them. So that has to be made much more faster. And now, 15 years later, we actually are understanding much better how to train people to find these lesions. And we really wanted to share with everyone how to find these flat lesions.
Okay. All right, there's a question for Selvi and Silvia. This is from Maha. Low dose aspirin and MDACC. What's the role in decreasing polyps in the future?
Sylvia, I'll let you answer that.
Yes, I can provide my experience. There are indeed data suggesting that daily aspirin may decrease the risk of colorectal and extracolonic cancer in Lynch syndrome. And as far as I know, currently, the evidence is not sufficiently robust or mature to make recommendations for its standard use. So we prescribed aspirin in trials, but it's not part of daily routine practice. And I'm aware that the CAP study, which studied actually the effect of aspirin on decreasing the risk of colorectal adenomas, cancer, and extracolonic cancer, recently published the 10-year follow-up data. It seems that aspirin has protective effect, and it seems that the adverse events are similar to the in the aspirin group and placebo, which was a little bit surprising to me. But the study was criticized because they still need very high doses, 300 milligrams daily, which is 3 times more than the 75, even more than 75 milligram daily, what we use in cardiology. And it was also criticized because, again, they did not include only mutation carriers. They included also patients with a family history of Lynch syndrome. And of course, the colorectal cancer diagnosis protocol differed between countries. So there is still so much to do in this area. So getting back to the question, no, we don't use it in daily practice.
That's good. So this is a question from Gabrielle. Do you biopsy all flat lesions or take a representative? Do you biopsy the entire flat lesion or take a representative biopsy from flat lesion? I think the most important thing, Gabrielle, is this. If you see a flat lesion and you think you can resect, you should resect it completely. On the other hand, if you think that you cannot resect and you don't think it is cancer, based on the surface and vascular pattern, take a small biopsy from the so-called worst area in terms of the microvascular pattern. Take a small biopsy and then put a tattoo 3 centimeters away from the lesion. Take a photo of the tattoo and the lesion and let somebody else take care of that. That's the best way to take care of these polyps. Do not biopsy, do not take a lot of biopsies, because if that lesion could be endoscopically resected, it becomes very hard for the endoscopist who's trying to resect due to extensive scar formation. So I hope that helps. All right. I don't see any other questions. If there are no other questions, I just want to thank Selvi and Silvia. Selvi and Silvia, do you want to post this thing on the YouTube?
Yes, of course. Of course,
Okay.
I would be happy to share.
All right. All right. All right. Thank you. Thanks, everybody.
Thanks a lot.
Thanks for your support.
Thank you.
Thank you so much.
Thank you. Thank you.
Thank you, Tanya.